Dear audience, I'm Dr. Lin. Today I will give a speech about the role of PM2.5 in the development and the deterioration of chronic obstructive pulmonary disease, COPD, and how to treat the COPD disease. This is my outline. First, I want to introduce what is PM2.5. Second, the harm PM2.5 to human health. Third, the diagnosis and evaluation of COPD. Fourth, how to manage COPD disease. How is the air pollution around us caused? According to the source, it can be divided into two parts, from nature or from human. There are many ways to develop natural air pollution. For example, in sandy land lacking plant cover, sandstorms will be formed by the passage of strong winds. The weathered rocks make fine sand and dust floating in the air. The forest fires and volcanic eruptions would make severe air pollution. The advance of human civilization brings convenience to life, but it creates a lot of environmental pollution at the same time. Human-made air pollution would be caused by industrial waste gas, vehicle exhaust gas, cooking fuel, waste burning, and construction industry. The burning of fossil fuels often causes many toxic air pollution, such as sulfur dioxide, sulfur trioxide, ozone, nitro monoxide, nitro dioxide, hydrogen carbons, and carbon monoxide, and PM2.5. PM2.5 has attracted widespread attention in recent years. What is PM2.5? It is a teeny particles or droplets in the air. The diameter of PM2.5 is less than 2.5 micrometer. It is 28 times less than the hair. Its surface often contains toxic agents like dioxin or heavy metal. PM2.5 has been recognized by the International Agency for Research on Cancer, IARC, as a first-level carcinogen. They can produce a variety of cancers. This is a global map drawing based on PM2.5 concentration. From the map, we know that China, India, Middle East, and Africa are the areas with the highest PM2.5, but their causes may be different. China and India have the largest populations in the world, and their PM2.5 is mostly related to human activities and industry. The area with highest concentration in the Middle East and Africa are desert land. Their causes are related to the natural occurring PM2.5. Oil production worsened the air condition in Middle East. The rectangular chart below shows the Qatar is one of the richest countries in Asia due to its natural gas and oil production, but the air quality is the worst in the world. This is a very beautiful photo. When we are in the clean air, we can clearly see the mountains in the distance. Inhaled air can give people a refreshing feeling. Compared to the previous slide, this is a very bad photo. When the air quality deteriorates, the world we see is gray. The air we breathe in is sometimes full of bad smells. Poor air quality makes us wear masks every day when we go out. It has a great impact on the daily life. Poor vision caused by the air pollution and excessive moisture are not the same. The former is called smoke. The latter is fog. The fog is composed of water vapor. Exposure to the fog will make the clothes wet. It is harmless to humans. Smoke is composed by harmful substances floating in the air. Its particles are smaller than the fog. It is dry in nature. Its inhalation is harm to human health. The vertical axis of this feature is the deposition rate of the material in the lungs, and the horizontal axis is the size of the material particles. From the figure, we know that the smoke with small particles leads to the high deposition rate in the lungs. The fog with the large particle was restricted in the tracheobronchial area. More toxic substances retained in the lungs result to a severe health problem. The second part is to introduce the harm of PM2.5 to human health. According to the World Health Organization (WHO) report, 4.2 million people died every year due to outdoor air pollution. 3.8 million people died due to poor indoor ventilation and indoor air pollution. According to the WHO air standards, 91% of the world's population lives with the air pollution every day. After PM2.5 inhaled by the nose, the damage is not limited to the lungs. PM2.5 particle is very small. It will be absorbed through the pulmonary blood vessel and spread throughout the body, causes serious damage to systemic organs. In lungs, it will increase the chance of COPD, asthma, and lung cancer. It can also lead to higher incidence of cardiovascular disease, hypertension, diabetes mellitus, hyperlipidemia, and chronic kidney disease. Women are more likely to suffer from ovarian cancer and infertility. For newborns, it can lead to low birth weight, stunted growth. According to Taiwan research in 2014, PM2.5 causes 6,282 deaths that year. The main cause of death comes from increased ischemic heart disease, stroke, pneumonia, and COPD disease. WHO reminds us air pollution may not always be visible, but it is fatal. Due to the impact of air pollution, the proportion of human deaths from lung cancer increased by 29%. Deaths from stroke increased by 24%. Deaths from the heart failure increased by 25%, and deaths from the lung disease increased by 43%. WHO announced the top 10 causes of global deaths in 2019. The first is ischemic heart disease, the second is stroke, and the third is COPD. The top three are all related to air pollution, and the number of deaths is increasing year by year. In particular, COPD has risen from the fifth in 2000 to the third in 2019. The prevention and control of air pollution to keep children away from the dirty air requires everyone's participation. When cooking at home, attention should be paid to internal ventilation equipment, forbid to burn trash outdoors, mandatory requirement for factory to improve waste gas treatment equipment, penalize offenders and make improvements within a time limit. You need municipalities and countries to formulate regulations and conventions to encourage participants and punish violations of the rules. Provide regular physical examination for the high-risk groups exposure to air pollution. teach them how to protect themselves. As the previous description, COPD is currently the third leading cause of death in the world. Next, we are going to introduce the diagnosis and evaluation of COPD. What are the risk factors for COPD? In terms of gender, the incidence is higher for men than women. Inhalation of toxic air such as smoking, cooking oil fume, industrial dust, and factory waste gas can cause injury to lung and bronchi. The long-term accumulation of these injuries will cause narrowing of small airways, sputum production, alveolar destruction, ventilation impedance, and air trapping. Therefore, those over 40 years old are more likely to develop COPD. Other risk factors also cause COPD. Alpha-1 antitrypsin is a protease inhibitor produced by liver and enter the lungs. It will protect alveoli from the protease injury. Neutrophils secrete elastase to damage aged cells and bacteria. Alpha-1 antitrypsin gene defect will make lung injury by neutrophil elastase and develop COPD at a young age. Babies with a low birth weight may have poor lung development. This may result to develop COPD disease. After severe lung infection such as pulmonary tuberculosis infection, the injured bronchi and lungs would lead to structural damage, which causes airflow limitation and dyspnea. In addition, people with low socioeconomic status, history of asthma with poor disease control, or chronic bronchitis are also likely to develop COPD in the future. In this picture, the right lung is a healthy lung. It has pink alveoli and spacious bronchi. The lung on the left is damaged by long-term inhaled of toxic substance, causing the destruction of alveoli and forming plaque emphysema. The bronchial damage causes increased flame production and narrow airways, which causes airflow obstruction. They are the main pathophysiology of COPD. This is an anatomic photo of the lungs from a COPD patient. The black area in the photo are distracted alveoli, emphysema. A lot of white mucus blocked the bronchus. Emphysema and chronic bronchitis are the two leading characteristics in COPD. In many countries, the COPD prevalence rate in the population over 40 years old is very high. In Taiwan, 9.5% of adults over the age of 40 suffer from COPD. The incidence in the United States or Uruguay is as high as 20%. This is a very important issue. According to the research data from WHO, the number of people suffering from COPD reached 250 million in the world in 2016. The number of deaths in 1 year reaches 3.17 million. At that time, the death rate was ranked fourth. The research in Taiwan found that 1 in 4 people who smoked over the age of 40 suffer from COPD. The number of deaths that year was more than 6,700. COPD ranked 7th in the causes of death in Taiwan. In addition, COPD also causes a serious economic burden. In 2011, according to European statistics, medical expenditure due to this disease were as high as 38.6 billion euros, which is equivalent to 56% of the total expenditure on respiratory diseases. In the United States, it costs 29.5 billion US dollars each year. Taiwan's health insurance expenditure for COPD is also as high as 5.81 billion new Taiwan dollars. The typical symptoms of COPD are chronic cough, sputum production, and dyspnea. About 30% of patients would suffer from chronic cough. The characteristics of dyspnea in COPD is persistent, progressive, and exertional. It is different from asthma. If the asthma patient is under well control, he will not feel the sensation of breathlessness. For COPD patients, even if he accepts well medical control, he still feels labored breathing. This dyspnea symptom will aggravate as the patient continues to smoke or be older. Dyspnea will be worsened during exercise. This feature makes it difficult for patients to distinguish whether this is pulmonary disease or heart problem. In terms of diagnosis, if the patient is older than 40 years old and they have typical symptoms and risk factors, we will suggest a pulmonary function test for him. If the report of the test describes positive airflow limitation by FEV1 divided by FVC less than 0.7, he will be diagnosed as COPD. For the quantitative assessment of dyspnea, we often use MMRC scale. There are 5 grades for dyspnea. Grade 0 means I only get breathless with strenuous exercise. Grade 1, I get short of breath when I hurrying on the level or walking up a slight hill. Grade 2, I walk slower than the people of the same age on the hill because of breathlessness, or I have to stop for breath when walking on my own path on the level. Grade 3, I stop for breath after walking about 100 meters or after a few minutes on the level. Grade 4, I'm too breathless to leave the house, or I am breathless when dressing or undressing. During the COPD treatment, some patients will experience acute deterioration of symptoms. Acute exacerbation refers to the rapid worsening of symptoms, require additional medicine and hospitalization for disease control. For mild acute exacerbations, only short-acting bronchodilators are needed to relieve symptoms. For moderate acute exacerbation, in addition to bronchodilators, antibiotics and oral steroids are needed to control the disease. For severe acute exacerbation, patients require hospitalization or emergency medical treatment to deal with the worsening disease. 3 problems that patients need to face after acute exacerbation. The first is the deteriorating quality of life because the recovery of respiratory function cannot be completed in a short period of time. The second is the risk of acute exacerbation in the following year will increase substantially. The third is the mortality rate within 1 year after discharge in hospital patients will be 20% higher than in patients without acute exacerbation. What causes acute exacerbation? The most common cause is respiratory tract infection. Respiratory viral infection is an important problem. Therefore, patients are advised to administer influenza vaccine and vaccinate against Streptococcus pneumonia. The second is air pollution and large temperature variation. And some cause of acute exacerbation is unknown. According to the previous studies on the impact of PM2.5 on COPD, when PM2.5 raises by 10 microgram per cubic meter for 7 days, the percentage of COPD patients admitted to hospital or died to COPD acute exacerbation increased 3% and 2.5% separately. When the average daily concentration of PM2.5 rises by 10 microgram per cubic meters, the prevalence of COPD will increase. In terms of lung function, FEV1 and FVC will drop by 26 milliliter and 28 milliliter separately. So patients with COPD should be prohibited from going out when the air is bad. The use of indoor air purifiers can also reduce the influence of the factor. In the next part, we are going to discuss how to manage the COPD disease. There are two goals of COPD treatment. The first is to reduce patient symptoms. The second is to reduce future risk. In terms of reducing patient symptoms, it including alleviating patients' uncomfortable symptoms, increasing patients' exercise tolerance, and promoting health. The part of reducing future risk including slowing down the progression of COPD disease, preventing the acute exacerbation of COPD, and reducing patient mortality. In terms of non-drug treatment, pulmonary rehabilitation is the most important. Pulmonary rehabilitation not only promotes patient exercise, but also includes other aspects. The first step of pulmonary rehabilitation is to establish good living habits. One of the most important is to quit smoking. Because smoking is the most important risk factor causing COPD. And the most effective way to improve lung function decline is to quit smoking, not drug therapy. Developing good sleep, diet, and exercise plan is very important too. Regular flu vaccine administration and the injection of Streptococcus pneumonia vaccine can prevent COPD acute exacerbation. Pulmonary rehabilitation also includes teaching patients how to use inhaled drug correctly. Formulating an action plan. Action plan includes avoiding trigger factors, recording and dealing with uncomfortable symptoms, and how to urgently contact medical resources when COPD acute exacerbation occurs. By exercise training, let patients improving muscle power and return to normal life. Give palliative medical intervention and end-of-life care for patients with severe COPD disease. In other non-pharmacological therapy, there are oxygen therapy, ventilator, and surgery. Who should accept oxygen therapy? According to the current evidence, only patients with severe hypoxia will benefit from it. The criteria include: first, arterial oxygenation saturation is less than 88%. 2. Arterial oxygen saturation is between 88 and 90%, and the patient has the symptom of right heart failure and erythrocytosis. Furthermore, ventilator therapy for patients with chronic respiratory failure can relieve the patient's symptoms, but cannot improve the patient's quality of life. In the aspect of surgery, for patients with severe emphysema predominantly in the upper lobes or large bullae that causes ventilatory disorder, lung volume reduction surgery is helpful. If emphysema is homogeneous, lung transplantation will be suggested. This is very important. Pharmacological therapy can relieve symptoms, reduce acute exacerbation rate, increase exercise tolerance, and promote life quality, but it can slow down the velocity of lung function decline. The only way to change lung function decline slope is to stop smoking. The treatment drugs for COPD are mainly inhaled drugs. Inhaled drugs are designed to directly act on the site of the disease to reduce systemic side effects. This picture shows a lot of inhaled medicines. How to choose the appropriate inhaled medicine for different patients. The answer requires patient and the physician to understand the disease phenotype and the characteristics of the patient. This medicine have a common use skill. That is, exhale first, then inhale the medicine, and hold breath. This action let medicine have a good lung deposition. Smoking can lead to systemic inflammation and injury. The characteristics of smoking and the elderly brings COPD patients many comorbidities, including anxiety, depression, lung cancer, bronchiectasis, cardiovascular disease, diabetes mellitus, sleep apnea, osteoporosis, acid reflux. Cardiovascular disease is the most common comorbidities in COPD. Those comorbidities all influence patients' symptoms and life quality. They should be put into consideration when we initiate COPD therapy. Therefore, to treat COPD patients needs cross-team cooperation. The above is the content of my speech today. Thanks for your participation. Thank you.